Okay, we have started. Have we not? Yep, we have started. So again, because I wasted all this time, and even now I wasted kind of it, but I think I will stick to this plan right now, and I'll try my best to do it. Although I doubt I can finish CNS, I can go until the examination, and who knows? Maybe tomorrow morning, very early before I go to college, I'll just finish it off. But until then, let's start off. So examination of individual organs, palpation and percussion of the abdomen. The following scheme is suggested for palpating the abdomen, which we have already talked about. Then examination of individual organs, examination of liver. We have location: right hypochondriac, epigastric region, and left hypochondriac region. Extent is upper border is the sixth lib anteriorly. Inferior border is crosses the midline and the level of transpyloric plane at L1 vertebra. Transfer and L5 maybe L4 L5. Then watch for the fullness in right hypochondrium and epigastrum. Epigastrum usually presents left lobe. Then direction of enlargement is towards the right iliac fossa. I will always enlarge like this from the top left to the bottom right. So palpation. The following methods of palpation have been discussed. You have traditional or conventional method. You have preferred method. You have alternate method and hooking method. And also the dipping method, which is kind of good. So traditional or conventional, you put the right hand on the right iliac fossa parallel, and you keep the hand steady during inspiration and feel for the leverage. You keep on going like this as it descends with each inspiration. If the edge is not felt, move the hand upward to the costal motion by 1 centimeter during expiration. Inspiration you press, and expiration you move it up. Inspiration plus expiration over. Then preferred method, you sit on the right side of the patient facing the head of the patient, and now we place both hands side to side flat on the abdomen and the right subcostal region lateral to the rectus with fingers pointing the ribs. And if resistance is felt, you move the hands further down until resistance disappears. Gentle pressure exerted over and ask the patient to inspire deeply. Border of levers can be felt on the tips of the fingertip. This pressure can be repeated from lateral to medial to trace the entire edge of the liver. Right subcostal region lateral to the rectus with fingers pointing towards the right. You have to keep it like this. Right subcostal region. Then you keep on going down until you feel the liver. That is the preferred method. Alternative method is press the right hand below and parallel to the right subcostal margin. Liver edge will then be felt against the radial border of the index finger. So it will be felt here. We keep on doing like this, but in one hand instead of fingertips. Working method is you stand so this right shoulder. You sit the right shoulder, examine the lower edge by curling the finger and the right costal margin. Dipping method for liver palpation in ascites, you press both hands one over the other in the area to be palpable. Rapidly flex your metapharyngeal joints so that fingers suddenly dip into the abdomen. This displaces fluid, enhancing the palpation of underlying organ. You have to do it. You have to keep on doing it like this so that it will displace the fluid. Liver span. Liver span is the distance in centimeter between the upper lobe of the liver in the right mid-clavicular line. It is determined by percussion. It changes to liver dullness, and the upper bottom of the liver is using a heavy percussion technique. Light percussion is used to locate the lower edge of the liver. Light percussion is required because heavy percussion may underestimate the lower extent of the liver border. So normal liver span is less than 13 centimeter. In mid-clavicular line, it is 6 to 12 centimeter. In mid-sternal line, it is normally 4 to 8 centimeter. The clinical estimate of the liver span is actually an underestimation of the actual liver size by about 2 to 5 centimeters. Liver span is increased in hepatomegaly. It is decreased in shrunken liver as in cirrhosis. False positive for enlarged liver is right side of liver effusion and right lower lobe consolidation. Note, in conditions like emphysema of the lung, the liver may be pushed down. The edge may be palpable, leading the examiner to believe that the patient has a catatonia, when in reality it is a hyperinflated lung. Percussion reveal that upper powder is lower than expected. Clipping method. Yeah. So this is how you do the liver span. Focus on the midclavicular and focus mark the upper border of illness. If the liver is enlarged and palpable, assess the following: location of the edge in centimeter below the costal margin, in mid-clavicular or anterior axillary line. Below the costal margin in the mid-clavicular or anterior axillary line. Span in centimeter and tenderness, tender or non-tender. Tender hepatomegaly is seen in right heart failure, acute hepatitis, viral alcoholic drug-induced, liver abscess, amoebic or pyogenic, hepatoma, infarct, actinomycosis, and acute Budd-Chiari syndrome. Painless hepatomegaly is seen in fatty liver, infiltrative and storage disorders, malaria, leukemia, lymphoma. Margins, you have regular, irregular, rounded, or sharp. It can be in cancers, liver edge may be irregular, rounded, infiltrative. Rounded is infiltrative disorders. Sharp is secondary metastasis, acute hepatitis, biliary obstruction, and chronic hepatitis. Surface smooth or nodular. Smooth is malaria, acute hepatitis, and infiltrative disorders. Nodular is metastatic cancer, hepatoma, alcoholic cirrhosis, micronodular, and post-hepatic cirrhosis, macronodular. Yeah, so sorry about that. We have surface smooth, malaria, acute hepatitis, infiltrative disorders, etc. Nodular is seen in metastatic cancer, hepatoma, and alcoholic cirrhosis, micronodular, and post-hepatic cirrhosis, which is macronodular. So consistency, it can be soft, firm, or hard. In metastatic cancers and in obstructive jaundice, the liver is typically hard, firm to hard. Pulsatility, it is either pulsatile or non-pulsatile. The pulsatile liver may be present in tricuspid regurgitation, which is systolic, and tricuspid stenosis, which is diastolic. Hepatocellular carcinoma and hemangiomas also can depict pulsatility. May be present in tricuspid regurgitation, which is systolic, or it can be present in tricuspid stenosis, which is diastolic. Hepatocellular carcinoma and hemangiomas. Tricuspid regurgitation, which is systolic, and tricuspid stenosis, which is diastolic. Hepatocellular carcinoma and hemangiomas. Okay. Pulsatility, okay. Consistency, in metastatic cancer and obstructive jaundice, liver is typically bound to have ausculto percussion method. It is a scratch test. Diaphragm of the stethoscope is placed over the referred process or just superior to the costal margin and along the mid-clavicular line. Examiner then gently scratches the skin along the right mid-clavicular line, starting in the lower underbone and crossing to the hand. We have a sculptor persuasion method, which is a scratch test. Examiner gently scratches the skin along the midclavicular line, starting in the lower abdomen and advancing towards the head. The sound produced by the scratching sound changes in quality and intensity when over the liver, as sounds are much more easily transmitted through the solid organ. So, causes of hepatomegaly you can be grossly grouped under the headings of infections, malignancies, infiltrative disorders, hematological disorders, and vascular disorders, as shown in the figure. Malignancy, primary hepatocellular carcinoma, metastasis, leukemia, lymphoma. Infiltration, you have fatty liver and amyloidosis. Hematological, you have hemolytic anemia, myelofibrosis, myeloproliferative disorders. You have plasms. Vascular, you have right heart failure and hepatic vein thrombosis. Others, you have alcoholic liver disease, and you have infections, which is viral hepatitis A, B, C, Epstein-Barr virus, malaria, parasitic. Massive hepatomegaly more than 10 centimeter is seen with hepatoma. Little bit of mild hepatomegaly. Okay, then caudate lobe. Okay, so it arises from the right lobe of the liver on the posterior superior surface. This is the caudate lobe. And hypertrophy of the caudate lobe is characteristic of hepatic outflow obstruction, which is a Budd-Chiari syndrome. It will be hypertrophied. So then you also have a radial slope, although I don't think you can actually find out clinically. Then you have a radial slope, which is a congenital variant projecting from the right lobe of the liver. May be mistaken for gallbladder or right kidney. Congenital variant projecting from the right lobe. Okay, then examination of the spleen. Normal dimensions is 13 into 12 into 7. 13 is cranocaudal diameter, 12 is the length, 7 is the width. I think even 5 centimeter I say, but no, we don't require. 12, 13, 12, no, 13, 12, 7. Then weight is less than 250 grams. Weight is located along the 9, 10, 11th ribs mid axillary line, along the length of 10th rib, and along the length of 10th rib, along the long axis of the 10th rib. Then extent is anteriorly, it is lower pole is up to mid axillary line. Then posteriorly is superior angle of spleen is 4 centimeter lateral to the T10 spine, 4 centimeter lateral, whereas anterior lower pole superior angle of spleen is 4 centimeter lateral to T10. Margin, there is a notch on the inferior lateral position border. This may be palpated when the spleen is enlarged. Splenic notch. So normal spleen is not palpable clinically except in the following scenarios. Only occasionally palpable in 1 to 3% of newborn population. Tip may be palpable in newborns up to 3 months of age. Generally, it's not palpable. Splenic enlargement. Before it becomes clinically palpable, spleen enlarges in superior and posterior direction. It has to enlarge 2 to 3 times of normal to become palpable. Once palpable, it appears felt below the 10th rib, beneath or under the left costal margin, and further enlarges downwards and medially. It will come to this and forwards towards the umbilicus, left hypochondriac to right inferior right iliac fossa. Then grading of enlargement of splenomegaly, it is based on largest diameter. Moderate splenomegaly is 11 to 20 centimeter. Severe splenomegaly is more than 20 centimeters. Then based on the distance from costal margin, mild is tip enlargement, which is 1 to 2 centimeter, less than 3 centimeter. Moderate enlargement is 3 to 7 or 3 to 8 centimeter between the costal margin and the umbilicus. And severe, which is marked enlargement, is 7 plus centimeter below the left costal margin, more than 1000 gram dry weight and crossing the midline. So yeah, based on largest diameter, 11 to the mild, moderate and severe. So in the brackets, whatever they have given is actually the actual length, but because you cannot palpate like 1 centimeter, so yeah, because you calculate it from distance from costal margin. Then size of the spleen is measured from the left costal margin to the tip along the long axis of the spleen. So tip enlargement 1 to 2 centimeter, and moderate enlargement 3 to 7 centimeter, marked enlargement 7 centimeter. Then grading system power purple spleen available. We have grade 0, 1, 2, 3, and 4 and 5. So grade 0 is impalpable spleen, 1 is palpable only in deep inspiration, 2 is spleen palpable on mid-clavicular line halfway between umbilicus and costal margin, 3 is spleen expands towards the umbilicus, 4 is going past the umbilicus, 5 is expanding towards the pubic symphysis. Inspection. Fullness may be seen emerging from the left upper quadrant extending diagonally towards the inferior right, right iliac fossa, lower quadrant. Palpation, you can do 3 methods. Classical method, bimanual method in supine and right lateral position, and hooking method in supine and right lateral method, and Middleton's maneuver and dipping method. Classical method is you use a single right hand, place the hand in the right iliac fossa, lower quadrant, and move diagonally towards the upper left quadrant. Hand should be firmly placed on the abdominal wall. Keep the hand steady during inspiration and feel for spinning and as it descends with each inspiration. Using only one hand. If the edge is not wet, move the hand more diagonally towards the left upper quadrant by 1 centimeter during inspiration. Expiration. Repeat the procedure. Tip of the hands are used to feel the spleen. Bimanual supine position. Place the palm on the palm of the left hand over the lowermost rib cage posterolaterally, restricting the expansion of the lower ribs on inspiration, while applying firm pressure on the left hand. Ask the patient to take a deep inspiration. Insinuate the right hand between the left costal margin and feel for spinning edge. This is in supine position. You keep it like this from the right side. You keep it like this and spin. Bimanual, it is a right lateral position. It is done with patient lying in the right lateral position with the left hip and knee flexed. Rest of the maneuver is similar to above. Okay, because the gravity will work now, so you prevent the movement of the left rib and you palpate a little bit like this. Okay. Hooking method. In supine position, the physician hooks the finger beneath the left costal margin as the patient inspires. For better appreciability, patient is asked to lie down on his left fist, just inferior to his left scapula. Lie down on his left fist, just inferior to the left scapula. From above, spleen may be contently palpable with 2 hands as seen below, and the left costal margin. From the patient, when the patient is asked to take deep inspiration and breathing out slowly. Okay, method. Then right lateral position, as the patient in left side facing towards the forehead. With one hand, hook the left costal margin, and the other hand, give the counter pressure from the posterior lateral aspect. Now ask the patient to take a deep inspiration and feel for the tip of the spleen by hooking the fingers. Then dipping method. Similar to muscular ascites, it is similar to level of this same things. Then methods of percussion have been discussed. You have Castell's method, top by space percussion, and Nixon's method of percussion. So percussion by Castell's method, you have spring percussion. Patient in supine position percuss the lower left intercostal space in the anterior axillary line. Usually 8th or 9th intercostal space is the Castle point. So this space should remain resonant during full inspiration. There is the hooking maneuver. You have to percuss the lower left intercostal space in anterior axillary line. Castell's method of percussion. Dullness on full inspiration indicates possible swelling enlargement. A positive Castell sign. Most sensitive of all clinical signs with sensitivity 82%, specificity is 83%. Full inspiration, full expiration, you have the results. Percussion sign is considered positive and the change in percussion is noted between Note this in percussion note is observed between full expression and full expression. So percussion traverse, and this is Castell's point, 8th or 9th intercostal phase. Percussion of traverse, similar space. It is similar space in the left anterior chest, bounded by, above by 6th rib, below by left costal margin, and laterally by mid-axial line. In this space, the inferior and with patient supine purpose inferior to lung resonant from medial to lateral. Normally, a tympanic node is heard due to gastric evals. So, obliteration of traverse. So, obliteration is seen in massive splenomegaly, left side pleural effusion, pericardial effusion, enlarged left lobe of the liver, and full stomach of fundic mass. Upward shift of traverse space is seen in left diaphragmatic paralysis, left lower lobe collapse, or fibrosis. Posterior axillary line in right lateral position, which is Nixon's position. This is the traverse line. Percussion starts at the midpoint of left costal margin and is continued upwards perpendicular to the left costal margin. Right lateral decubitus position, you have the costal margin, you have the midpoint, costal margin, you have the cephalic process, and now splenic location. We really have a lot of landmarks, but I do not understand. Normally, the level of dullness does not extend further beyond 8 cm below the costal margin. Splenomegaly is diagnosed if the dullness extends beyond 8 cm. Midpoint of left costal margin and is continued upward perpendicularly to the left costal margin. You keep on going up like this and till you meet the left costal margin. Okay. And causes of splenomegaly: mild, moderate, and severe. Mild is acute infection, septic shock, infective endocarditis, entry fever, infective hepatitis, mononucleosis, brucellosis, cytomegalovirus, toxoplasmosis. Chronic infection is tuberculosis, syphilis, and brucellosis. Chronic bacteremia, HIV. Then parasitic is malaria, Kala-Azar, schistosomiasis. Inflammation is rheumatoid arthritis, sarcoidosis, SLE. Others have congestive cardiac failure and thalassemia major. Moderate splenomegaly is neoplastic lymphoma, acute leukemias, chronic lymphocytic leukemia, chronic myeloid leukemia. Non-neoplastic, you have cirrhosis of liver with portal hypertension, chronic hemolytic anemia, malaria, Kala-Azar, sarcoidosis, infectious mononucleosis, splenic abscess and amyloidosis, hemochromatosis, and polycythemia vera. Then you have massive splenomegaly, which is common causes are chronic myeloid leukemia, myelofibrosis, Kala-Azar, primary splenic lymphomas, hairy cell, mantle cell, marginal B cell, portal hypertension, extrahepatic portal vein thrombosis, hyperreactive malaria splenomegaly, topical splenomegaly. Massive lymphomas of leukemia is moderate, non-neoplastic cirrhosis of liver, sarcoidosis infections. But massive is the only thing which is important. You have it is a lot of things have what do you say? Same common things. Common causes are the chronic myeloid leukemia, fibrosis, primary splenic lymphomas, hairy cell, mantle cell, marginal B cell, portal hypertension, extrahepatic portal vein thrombosis. hyperreactive malarial splenomegaly, topical splenomegaly. Uncommon causes, you have Gaucher's disease, Neil Pigment's disease, thalassemia major, spleen cysts, and tumors of spleen, mycobacterium avium complex, MAC infection in HIV patients. Then causes of hepatosplenomegaly, common causes of hepatosplenomegaly, and associated features have been illustrated. Then location of the gallbladder located. It is located in the lateral edge of the rectus abdominis, near the tip of the right ninth intercostal margin. It moves with respiration. Near the tip of right ninth costal margin, lateral to the edge of rectus abdominis, and it moves with inspiration. Upper border continues with the liver. You have anemia, hemolytic anemia, malaria, leukemia, lymphoma. Lymph node is, you have a few things: anemia, jaundice, you have hemolytic anemia, typhoid fever, leptospirosis, cirrhosis, congestive heart failure. Lymph node, you have CLL, chronic lymphocytic leukemia and lymphoma. Bone pain, you have chronic myeloid leukemia, lymphoma, multiple myeloma, and hemolytic anemia. Causes of enlarged gallbladder, you have carcinoma of the pancreas, common bile duct obstruction, mucocele of gallbladder, carcinoma of the gallbladder. Murphy's sign in acute cholecystitis, height of inspiration, patient stops breathing with a gasp as a mass is felt. You cannot breathe, the inspire very large, which we have talked about before also. Then you have Courvoisier law, which is in a jaundiced patient. If the gallbladder is palpable, it is unlikely to be due to a common bile duct gallstone obstruction. Then examination of the kidney, examination of the left kidney. You have in the right hand is placed anteriorly in the left lumbar region, while the left hand is placed posteriorly in the right loin. Yeah, I know. I'm telling you. You just push from the behind and like this. As you can see here, you can push from behind and you palpate from the front. That's all. Ask the patient to take a deep breath in. Press the left hand forward and right hand backward, upward and inward, backward, upward and inward. Then left kidney is usually not palpable except when it is lying low or enlarged. If it is palpable, it is described as bimanually palpable and palatable. Bimanual palpation, as can be felt as swelling between the right and left hands. Palatable, it can be pushed from one hand to the other. Doing. It is because of fat which allows the free movement of kidneys in the retroperitoneum. Okay, only difference between the right and left is that the lower pole of the right kidney, unlike the left, is commonly palpable in thin patient and is felt as smooth rounded swelling which can descend on inspiration. Then you have causes of unilateral and bilateral kidney enlargement. So unilateral kidney enlargement is renal cell carcinoma, hydronephrosis, and bilateral kidney enlargement is polycystic kidney and bilateral hydronephrosis. Mm, renal cell carcinoma, hydronephrosis. Bilateral is polycystic kidney disease, bilateral hydronephrosis. Renal cell carcinoma is, it is usually unilateral, while polycystic is caused by polycystic, there's a gene, ARBA gene, ARBA gene, I think so, but it is caused by a genic problem. It is of two types, it is dominant and it is recessive. Dominant is more common but less severe, and recessive is less common but more severe, I think. You have to do a lot of things to save the patient. So differences between left and spleen and left kidney. So characteristics, you have location. Spleen is located in the left hypochondrium and left kidney is located in the left lumbar. Direction of enlargement is like this. towards the right iliac fossa. However, left kidney is towards left hypochondrium and left iliac fossa, up and down. Movement with respiration is seen in the spleen, but is not seen in left kidney. Insinuation between left costal margin and organ is not possible in spleen. However, it is possible in left kidney. The space between left costal margin and the organ. Bimanual palpation is not possible in spleen. Palatability is not possible in spleen. It can cross spleen can cross the midline, and you can feel a notch, but there is no band of colonic resistance. There is a band of colonic resistance in left kidney because it is behind the colon. So yeah, this is the difference between spleen and left kidney. So we can have difference between liver and spleen versus kidney. Right hypochondrium, left chondrium, and kidney is lumbar. Then direction of enlargement is towards right iliac fossa, towards left iliac fossa, above and below. Then movement with respiration, yes, no. Lungs do not, livers, kidneys do not move with respiration, but the right lower pole of the right kidney, unlike the left, is commonly palpable and is felt as a smooth rounded swelling which descends on inspiration. This is the only exception in the patients. Then palatability, not palatable in any of them. You cannot push them between this and this, but kidney you can push. Anteriorly percussion, it is dull, and it is tympanic because it is a right iliac fossa. Then examination of free fluid in abdomen. This is the main question because decompensated, compensated liver diseases, all of them will, no, not compensated, decompensated liver disease will come with ascites. It is the main feature of liver. So, ascites is defined as accumulation of free fluid in the peritoneal cavity. Peritoneal cavity can accumulate as much as 60 liters of fluid. Massive ascites, intense ascites are the clinical terms and are described at the end. Then, etiology of ascites, you have non-peritoneal causes and peritoneal causes. So, non-peritoneal causes, you have intrahepatic portal hypertension, which is cirrhosis, fulminant hepatic failure, veno-occlusive disease. Extrahepatic portal hypertension is hepatic vein obstruction, which is Budd-Chiari syndrome, congestive heart failure. Hypoalbuminemia is nephrotic syndrome and protein losing encephalopathy. You have malnutrition, you have miscellaneous disorders like myxedema, ovarian tumors, pancreatic and biliary ascites, and ankylurus, which is secondary to malignant trauma. These are all the non-peritoneal causes. Okay, just a second. Etiology of ascites, hypoalbuminemia, miscellaneous disorders, and colitis. Okay, just a second. I will be right back. So I'm back. Just a second. Mm, Something's wrong with the camera. Yep. Now it's working. It's already 9 and I haven't finished yet. I still have another 10 pages to do, which will take an hour. But yeah, maybe just 20 minutes. Because, but this thing is the only main thing. Sorry, this thing is the only main thing in the entire GIT. If you can do this and if you can understand this, then you are pretty much done. The ascites. After ascites, cirrhosis is okay, and encephalopathy and anosmosis, bed cherry. That's it. Again, another 10 pages is here. So take with me, and I'll finish it off. So etiology of ascites, you have non-peritoneal and peritoneal causes. How much? 40 minutes. So I'll try to finish it in around. I'll do for another 10 minutes. I'll most definitely not be able to finish it because it is such an important and big topic. I will continue it after a little bit of a break. I have to have my dinner right now. It's 9 p.m. So yeah, let's continue. Etiology of ascites, you have non-peritoneal and peritoneal causes. Non-peritoneal, you have cirrhosis, fulminant hepatic failure, and obtrusive disease, and extrahepatic but Cherry syndrome, congestive heart failure, hypoanemia, nephrotic syndrome, protein-losing encephalopathy, malnutrition, myxedema, ovarian tumors, pancreatic and biliary ascites. So scalous, it is secondary to malignancy and trauma. Peritoneal causes is granulomatosis, cranulomatosis peritonitis, which is tuberculosis peritonitis, fungal imperatus, parasitic infection, sarcoidosis, foreign body is which are cotton, starch, barium. I can think. Malignant ascites is primary peritoneal mesothelioma, secondary peritoneal carcinomatosis. Vasculitis is systemic lupus erythematosus, Hohenschole purpura. Miscellaneous, you have eosinophilin, gastroenteritis, Whipple's disease, and endometriosis. Non-peritoneal and peritoneal causes. You have for ascites. So, peritoneal, intrahepatic, portal hypertension, extrahepatic, portal hypertension, hypoalbuminemia, miscellaneous disorder, myxedema, ovarian tumors, pancreatic and biliary atresia, and Kailas, which is secondary to malignancy. So, one important test is serum ascites globulin ascites albumin gradient SAAG. Albumin level of cirrhotic fluid. The serum ascites albumin gradient SAAG is better discriminant than older measures, which is translated to successful for the cause of ascites. If the gradient is more than 1.1 gram per deciliter, predicts that the patient has portal hypertension with 97% high accuracy. So high albumin gradient and low albumin gradient is there. Then high albumin gradient is cirrhosis, alcoholic hepatitis, heart failure, massive hepatic metastasis, failure and constructive pericarditis, and heart failure, constructive pericarditis, Cherry syndrome, portal vein thrombosis, and idiopathic portal fibrosis. Low albumin gradient is peritoneal carcinomatosis, then peritoneal tuberculosis, and pancreatitis, cirrhosis, nephrotic syndrome, biliary ascites, bowel obstruction, bowel infarction. Then you have ascites praecox, which is defined as appearance of ascites before the generalized edema. It is usually associated with chronic constructive pericarditis. The causes of ascites without significant edema are chronic constructive pericarditis, tuberculous peritonitis, malignant peritonitis, pancreatic ascites, acute Budd-Chiari syndrome. So grading systems of ascites, you have international ascites club grading and traditional system. So ascites club grading, you have mild ascites detectable only by ultrasonography is grade 1. 2 is moderate ascites manifested by moderate symmetrical abdominal distension, and 3 is large or gross ascites with marked abdominal distension. Whereas traditionally 1 is minimal and barely detectable, 2 is moderate, 3 is massive but not dense, 4 is massive and dense. Following method have been discussed for demonstration of ascites. You have fullness of flanks, you have horseshoe dullness, you have shifting dullness, you have a fluid wave or fluid thrill, and you have puddle sign and auscultatory percussion sign of Guarno. Now, bulging flanks and fullness of flanks, horseshoe dullness, occurs when the abdominal fluid it will be pushed towards the flanks. In inspiration, it can be filled as fullness of flank or bulging flanks. It can be caused by ascites or by obesity. One method for discriminating the two is to test for flank dullness. With the patient recumbent, gas-filled loops of the bladder will characteristically float up to the top of ascites, making the note tympanic at the umbilicus and dull beyond the fluid meniscus along the flanks, which is a horseshoe dullness. Because it will gas filled, so it will come up. Then shifting illness. Presence of shifting illness indicates at least 1.5 liters of free fluid in the peritoneal space. Patient is supine and you do percuss from about onwards till the midline. Then below the midline you get dullness. This dullness can be due to distended urinary bladder. Hence, repeat this after making the patient empty the bladder. Okay. Then you make the patient lie in lateral decubitus position. So you do once like this and you do once like this and you go like this. Then after that you make the patient lie in lateral decubitus position and you do the same thing again and you do the same thing in the right and left. Now begin percussing at the umbilicus moving towards the flanks. Okay. Then transition from air to fluid can be identified when the note changes to dull. Mark the dullness tympani transition point. Turn the patient to the opposite lateral side and wait for 1 minute, half a minute or 1 minute. Now percuss the area again. The area of tympani will shift towards the top of the area of dullness and so area of tympani will shift towards the top. Okay. Opposite to the opposite lateral side. So you do like this and he goes like this. Okay. Then you percuss the area again in the same way, in the same position. The area of tympani will shift towards the top and the area of dullness shift towards the bottom. Okay. All of the fluid will come like this and the loops of stomach will come like this. So you can do the same maneuver on the opposite side. So causes of ascites without shifting dullness. There is ascites, there is no shifting dullness. Is massive ascites and loculated ascites. So if there is a lot of ascites, there will be no shifting dullness. Then you have fluid wave assessment for ascites. In supine position, ask the patient to place ulnar surface on one hand, use one hand to palpate and the other to percuss. Place the hand on lateral aspect of the abdomen between the costal margin and the indium and the anterior. So you percuss like this, flick with the fingertip, feel on the opposite side, passing through the fluid. Repeat the procedure by flicking on the other side. So if it is possible, then its feasible palpable impulse is felt on the opposite side of tapping, suggesting ascites around more than 2 liters. In shifting illness, you need more than 1.5 liters, but here you need more than 2 liters. Negative, no impulse will be felt. False positive can be felt over a large ovarian cyst or large hyalid cyst or large hydronephrosis. Then, puddle sign is most common. It is a mild ascites, 250 ml. It is not frequently done. You ask them to be in knee elbow position and diaphragm of the stethoscope is placed on the most dependent part of the abdomen. Place the diaphragm of the stethoscope above the umbilical region and scratch the abdominal wall from periphery to umbilicus. There will be sudden change in the note. It can be false positive in case of massive splenomegaly or distended urinary bladder. Okay. Then you have Gorno's method. So after wording, the patient sits or stands so that free fluid gravitates towards the pelvis. The examiner places a stethoscope on the midline immediately below the pubic crest. Finger flicking percussion is performed along the radial spokes of the subcostal margin downwards towards the pelvis. Percussion note is initially dull but changes sharply to a loud note at the border of increased pelvic density. In the absence of ascites, the border is approximately 4.5 cm above the pelvic crest. The pelvic baseline. In patient with ascites, free fluid raises the demarcating boundary above the pelvic baseline. When the patient is supine, this clear line of demarcation is obliterated because the free fluid will go towards the flanks. Okay. Then you have sensitivity ratio. Okay, but before that, I'll show one thing. Shifting dullness positive in moderate ascites, tense ascites, but is not in massive ascites. Fluid thrill is positive in tense ascites and massive ascites, but not in moderate ascites. Okay, there is no mild, moderate, and massive. Shifting dullness is there for two of them, not for massive. This fluid cell is there for only massive. Shifting dullness is there for only moderate. Okay, that thing you should remember. Then sensitivity, specificity, and ratio, all of this thing is given, but this is really not important. Shifting dullness indicates 1.5 liter, fluid cell indicates 2 liters, and puddle sign is indicating of 250 ml. So what is tense ascites and massive ascites? The earliest clinical sign of ascites is puddle sign, which is positive to with as low as 250 ml of ascitic fluid. Shifting dullness is a specific sign of ascites which occurs due to floating of oil loops in ascitic fluid. It appears when around 1.2 liter fluid accumulates further. Fluid thrill appears around 2 liter. Appearance of fluid thrill marks ascitic tense. In ascitic, fluid fills, the mesentery is stretched and bowel loops float, and the ascitic fluid will be there. As the mesentery can only stretch up to a limit, further fluid accumulation results in submersion of bowel loops. At this stage, shifting dullness disappears, however, fluid thrill will be there. This is termed as massive ascites. And this schematic is very, very important. Okay. And that is all for ascites. After this, you have dilated veins. These are all the images of ascites. And next you have dilated veins, and finally you have around complication of cirrhosis, hepatic encephalopathy. It will take another 5 minutes. No, not 5 minutes. 15 minutes to finish this, but I am going to have my dinner. So I'll come back in a bit, but I believe it's already 9, and GATV I will finish by 10. Nothing else can be done. And CNS, if I am not sleeping, I will finish it by 2, by 3 in the morning. But I have college, so no, I don't have to be awake for going to college, so I'm pretty much going to stay up till 3, and I will try to finish CNS. But for now, actually no, I cannot make any promises which I cannot keep, so I'll just do this. Okay, so I'll keep you guys in blackout mode. Break. We'll continue at 9:15. Yeah, okay.
I'm warning you right now, this game is purely whack. Welcome to Pain Mayhem, a game that I expected to sit down and play 2 or 3 rounds of, and 2 or 3 rounds slowly turned into 10, into 15, into 20. Thank you to the devs for sponsoring this, but also screw the devs for sponsoring this because now I'm super addicted. Gain 2 rocks, lose 5 strength. That might be worth it. I think I actually might be beating these. Left slap is great too. You have to stun them for a whole second. Yeah, but like I have health regen in the beginning, right? So having them stun makes my health regen worthless. Okay, please tell me I'm good against this guy. Okay, so my health regen is going nuts. And eventually I'll get some crazy health regen. Okay. Oh, please finish him off, please. Thank God. Oof. This guy's caused some pain to me. Definitely gonna bag a flex. Okay, so health regen's pretty good. I don't love these. I guess I'll just. Well, cardio was fine actually. That's a good chunk of max HP. Yeah, actually, it's a pretty good chunk of max HP. Wow, 2 second win. Wow, 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 wow. Rocks get better. Yes, please. More strength damage. 187. 2 second win. Is this it? Is this the one? Plus rush. You gotta take the rush perks. After taking some medicine, you keep thinking every girl is a guy and every guy is a girl. More rush, more attack speed. Yes, 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 yes. Get him, get him, get him. 2 second win. When's the 1 second win? What's rated? Did you say he was zombie? Yeah, bro, he not needed. Nice. I'm literally a zombie. Yeah, higher crit chance, sure. ER goggles, max HP, or anything else. Like advanced stats, more armor and a 50 bonus. That Yes, I'm literally a 10,000 rating. Maximum attacks, 10 attacks speed.
Mm. Okay, I'm going to continue right now. So, yeah, something's wrong with my camera again. Just a second. Yep. Okay, so let's continue. Yeah. Yes, again, I think it'll go again one down, but it's okay. I will most definitely finish it tomorrow. There's no way I'm going to be able to finish it today. So let's go on. So, examination of dilated veins. So, examination of the patient, make the patient stand and examine the anterior abdominal wall, the flanks and back for dilated veins. Dilated tortuous veins are significant. So, you have Harvey signs. The direction of blood flow in veins is examined by placing the tips of the index finger together and compressing the vein. Then, when they are slid apart, produce an empty segment of vein in between the fingers. Then, one of the finger is removed and the filling of the vein is observed. The procedure is repeated, but now the opposite finger is removed and the filling is observed. The direction of flow of the veins is the direction in which the filling was rapid and more. Slow filling, fast filling, which is shown here. So normally the condition of veins is not visible. Normal veins are not visible. Direction of flow in veins above the umbilicus is upwards, below the umbilicus is downwards. Portal hypertension, the veins are visible and tortuous. The direction of flow is still upwards and down below the umbilicus is downwards. Portal thrombosis, there is inversion. Superior vena cava obstruction also, there is inversion. No, in portal vein thrombosis, there is inversion, that's it. So above the umbilicus, it will go downwards and below the umbilicus, it will go upwards. Then superior vena cava obstruction is it, then superior it is not going. So it will be going direction of flow of the tortuous veins will be from above to downwards because superior vena cava is not going. It has to go some other vena. So it will go via the accessory veins and it will go downwards and it will be below the umbilicus, it will be normal. Then inferior vena cava obstruction above the umbilicus will be normal because superior vena cava it will be normal, and below the umbilicus it will be upwards. This is not the exact reasoning as to why it is happening this way, but you can remember it like that. Because inferior vena cava is obstructed, it will go from all the tortuous veins will be activated and it will go from below upwards. Then caput medusa, dilated tortuous vein along the umbilicus, it is resembling a head of medusa. Then yes, you have the things. Then finger slips are slipped apart, producing an empty segment of vein between the fingers. One of the fingers is reduced and absorbed. Procedure is repeated. Opposite finger is undone. Okay. So portal hypertension, it is always caput medicine. Portal vein thrombosis, and less is there means it will come like this. Inferior vena cava is up, superior vena cava is down. That's the only thing. This is easier method to remember. This image, if you remember, it's more enough. Perrectal examination. Perrectal examination consists of visual inspection of the perianal skin, digital palpation of the rectum, assessment of neuromuscular function of the perineum. Preferred position of examination is lateral decubitus or Sims position. The way Sims sleep. You can remember it like that, but it's not the actual reason. I think Sims is a doctor name. Lateral decubitus or Sims position produce optimal examination. Patient lies on left hand with the buttocks near the edge of the examining table or the bedside with the right knee, a hip, slight flexion. Rectal examination involves both inspection and palpation. First, use a gloved hand. The inspector inspects the buttocks for the fistulous tract, skin tags, excoriation, blood fissures, and inflammatory bowel diseases, rectal prolapse, and superficial ulcers. Then tenderness may be felt with prostatitis, pelvic inflammatory disease, deep ovarian abscess, ovarian cyst, ectopic pregnancy, inflammatory bowel disease. Also note consistency, color, and presence of frank or occult blood in melena, black stools resulting from degraded blood, melena, Then iron, licorice, bismuth, rhubarb, or overindulgence in chocolate cookies. Overindulgence in chocolate cookies make black stools. Then red stools may be due to brisk bleeding known as hematochezia, usually in distal segment or trades. Distal to the ligament of trades. Hemorrhoids are usually not felt unless thrombosed. Proctoscopy is the best way to look for hemorrhoids. Then others you have pervaginal or perspiculum examination in patients with ascites, ovarian neoplasm, pelvic tumor, and pervaginal mass or bleeding can be detected. GIT examination is incomplete without examination of the three S's: scrotum, spine, and supraclavicular fossa. Scrotum is cytosol hernia, testicular atrophy, and testicular tumors. Spine is metastasis and Pott's tumor, and supraclavicular fossa is metastasis to left scalene nodule. So then we move on to the last 4 pages. Complications of cirrhosis is complication of cirrhosis: portal hypertension, sequel, ascites, spontaneous bacterial peritonitis, portopulmonary hypertension, coagulopathy, thrombocytopenia, hypokalemia. Oh my god, we have Ganesh Chaturthi events going on. Oh my god, they're not just. How much longer is this? Yeah, it's making a lot of noise. What do I do, man? What do I do? Okay. I guess the only thing I can do is wait until I have to wait until this thing is done. Okay, I don't think this is going to stop anytime quickly. Let me just make a scheme. Okay. Honestly, I'm going to finish JT. It's just little bit is left. Just complications, hepatic encephalopathy, hepatorenal syndrome, and you're done. So this is just images. You're done, bro. Fuck. It's a small thing which is left. Okay, wait. Complications. You have sequel, hypertension, and the sequel. Ascites is there. Spontaneous bacterial peritonitis, postopulmonary hypertension, coagulopathy, thrombocytopenia, hyponatremia, hepatic encephalopathy, postgastropathy, hepatorenal syndrome, hepatopulmonary syndrome, endocrine dysfunction, adrenal insufficiency, gonadal dysfunction, and thyroid dysfunction, hepatocellular carcinoma, bleeding manifestation, coagulopathy, cirrhotic cardiomyopathy, hepatic hydrothorax, and cirrhotic osteodystrophy. So, hepatic encephalopathy, types of hepatic encephalopathy is grade 0 or minimal HE, lack of detectable change in personality and behavior. One is lack of awareness, euphoria, anxiety, shortened attention span, impaired performance of the audition. Asterisks will be absent is in the grade 0, it may be present in grade 1. Grade 2 is lethargy, apathy, memory disorientation to time, place, person, subtle personality change, inappropriate behavior, third speech, impaired performance of traction. The asterisk is present. Solemnness or semi-stupor responsive to verbal stimuli is confusion and gross disorientation is grade 3. It is usually asterisk is usually absent. Only grade 2 obstetrics is present, and grade 4 is unresponsive to anything. So you have types of hepatic encephalopathy. Encephalopathy associated with acute liver disease is type 1. Type A with portosystemic bypass, no intrinsic liver disease is type 2. Encephalopathy associated with cirrhosis or portal hypertension or portosystemic shunts is type C. We have minimal hepatic encephalopathy, hepatic encephalopathy, and persistent hepatic encephalopathy. Episodic is precipitated, spontaneous, recurrent. Persistent hepatic encephalopathy is mild, severe, and treatment dependent. Asterixis is a sign of liver failure. Diagnosis of minimal hepatic encephalopathy is based on neuropsychometric tests, including the number connection test and digit symbol test and the block design test. Retains number connection test. There are 25 number circles which can be joined within 30 seconds. All of these following must be present. For hepatorenal syndrome, there is cirrhosis with ascites. Serum creatine is more than 1.5 mg per deciliter. There is no improvement in serum creatinine. Decreased to a level of 1.5 mg per deciliter or less after 2 days of diuretic withdrawal and volume expansion with albumin. There is absence of shock. There is no current or recent in treatment with nephrotoxic drugs. There is absence of parenchymal kidney disease as indicated by proteinuria more than 500 mg per day. Microhematuria will be there, more than 50 blood RBCs per high power feed, and albumin abnormal renal ultrasonography. Proteinuria will be there, microhematuria, and abnormal renal ultrasonography is absent. Absence of parenchymal kidney disease. All of these are absent. No current or treatment with nephrotoxic drugs. No absence of shock. No improvement of serum creatine. At least 2 days of diuretic without withdrawal and volume expansion with albumin. With diabetic withdrawal, at least 2 days after diuretic withdrawal and volume expansion with albumin. Cirrhosis with ascites. Serum creatinine more than 1.5 grams. No improvement with serum creatinine. Decreased to a level of 1.5 grams or less after 2 days of diuretic withdrawal and volume expansion with albumin. Absence of shock. No current or recent treatment with nephrotoxic drug, and no absence of parenchymal kidney disease. And this is the retains number connection test. Types of hepatorenal syndrome. You have type 1 is progressive oliguria, rapid rise of serum creatinine above 2.5 mg per deciliter, and poor prognosis, usually precipitated by spontaneous bacterial peritonitis. Without treatment, median survival is less than 1 month, and almost all patients dies within 10 weeks after onset of renal failure. Type 2 hepatorenal syndrome characterized by reduction in glomerular filtration, moderate and stable increase in serum creatinine, more than 2.5 mg per deciliter, but is fairly stable and has better outcome than type 1 hepatorenal syndrome. Usually occurs in patients with refractory ascites resistant to diuretics. Median survival is 3 to 6 months. Precipitating factors for hepatorenal syndrome are gastrointestinal bleeding, aggressive paracentesis, diuretic therapy, sepsis through spontaneous bacterial peritonitis, and diarrhea. Then sites of portosystemic anastomosis. We have all the different sites: pre-renal, renal, and we have esophagus vein, and it's coming to esophageal, and gastric veins, short gastric vein, lower esophageal, portal, esophageal, branches of left gastric veins, and systemic esophagus veins. Then you have caput medusae right over here. There is umbilical vein. Then number 2 is upper inner canal, portal is superior rectal vein, systemic is middle or inferior rectal vein. Umbilical portal veins of ligamentum teres, systemic is superior or inferior epigastric veins. 4 is bare area of the liver, and it is portal is hepatic portal veins, systemic is inferior phrenic veins. 5 is retroperitoneal, the portal is colonic vessel veins, and systemic is body wall vein. Splenic vein, inferior mesenteric vein, superior mesenteric vein, and superior rectal vein. So you have post-hepatic, post-sinusoidal, but serious syndrome. Intrahepatic, post-sinusoidal. The sinus is passed, but it's still in the hepatic. Is veno-occlusive disease. Sinusoidal is cirrhosis, polycystic liver disease, nodular regenerative hyperplasia, and metastatic malignant disease. Then sinusoidal is 5, 4, 3 is sinusoidal within the sinusoids. Then intrahepatic but pre-sinusoidal, you have schistosomiasis, congenital hepatic fibrosis, drugs, vinyl chloride, and sarcoidosis. But pre-hepatic, pre-sinusoidal, you have portal vein thrombosis due to sepsis, umbilical portal pyemia, or procoagulopathy, or secondary to cirrhosis, abdominal trauma including surgery. And just like that, we have finished GIT. It was around 10 minutes of studying, but finally we have to do only CNS. Oh my god. CNS will genuinely take 2 days to finish because it is such a difficult, large topic. Like, even just the pages. Like, this is just a case sheet. Yeah. So examination, it'll start at 326. I bet you 426 also will still be CNS. Yes, still CNS. 100 pages, still CNS. For 326. 100 pages is done. Still it is going on. Actually, you know something, let's just go 500. Yep, it's still CNS. Yeah, finally you are to gate. Yes, it is finally no longer CNS. We are almost ending it. Nope, it's still going on. 526, 200 pages, then it's still going. I think 550 will be different. Oh my god, it's still not done. Not even 550. Finally, 553. So it is 226 to 553. No, 326 to 556. 3. How much ever we have done till now, it will take exactly that much time to finish CNS. So, and I have 3 days to finish this. For my exams though, I need to finish this in 3 days. So actually make it 2 days. Because on day 3 I have to do something else now. Today and tomorrow. today and tomorrow I have to finish the entirety of CNS, which is again 220 pages. GAT was the smallest, 60 pages was the smallest. Imagine that 220 pages times 5, 220 times 5, it will be 1100. No, 1100 divided by 60, around 20 hours. 20 hours only for CNS, and I was like, I'll finish this in 5 hours. Not possible. GIT, okay, somehow I finished in 5 hours. GIT took for 5 hours. CNS will take 20 hours. Yeah, okay, let's get started. 220, no, 326. Give me a break for 5 minutes. I'll be right back. Yep, I found where the mic is. I'll be back in around a few minutes. God damn it. I hate, I hate CNS examination, but even another hour is gone. But I see somewhere around 4 hours. I think I can do still. Yeah, my aim is to finish until 376 pages. That's the only thing which I can do. Not even like, yeah, in 4 hours, 376 pages I can do. That's the only thing which I can expect to be done. Then tomorrow, there's so much, bro. Fuck. It makes me want to procrastinate, but okay. I will have to do this someday, so let me just do it today. What other job do I want to do? Maybe a little bit of. I want to play a little bit of games, so maybe I'll just finish until 350 at least. I'll finish the discussion on the cardinal symptoms at least. So diagnosis format, you have general format, nature of disease, onset and deficit. Onset is acute, subacute, chronic, acute, sudden. Sudden is vascular, acute is demyelinating, subacute is infections and space occupying lesions, and chronic is degenerative. Deficit may be monophagia, hemiplegia, quadriplegia, paraplegia, nerve palsies, ataxia, sensory disturbance, movement disorders. So, site of involvement of nervous system, you can have upper motor neuron disease and lower motor neuron disease. Upper motor neuron disease is intracranial, brain or cerebellum, or extracranial, or which is the spinal cord. Lower motor disease is anterior horn cell disease, reticulopathies, neuropathies, neuromuscular junction diseases, and myelopathies. So, for cerebrovascular accident, you need to say sudden onset, right-sided, dense hemiplegia with right upper motor neuron, UMN, facial palsy due to cerebrovascular accident, possible thrombotic in etiology with site of lesion being left internal capsule, possibly involving the reticulostriate branch of middle cerebral artery (MCA). Patient is in a state of neuronal shock, and patient has the following risk factors. For neuropathy, acute onset, symmetrical, flaccid quadriplegia, ascending with no evidence of sensory bowel bladder involvement, with bilateral lower motor neuron element, facial palsy. Possible site of lesion is the peripheral nerve. Pathology being demyelinating acute inflammatory demyelinating polyneuropathy (AIDP). For spinal cord disease, a subacute onset of symmetrical spastic paraplegia with involvement of sensory, bladder, and bowel, with no involvement of cranial nerves, with vertebral tenderness at T4, T5, with possible site of lesion being the spinal cord, the disease being compressive myelopathy. So, horizontal level you have extradural, extramedullary, and vertical level you have motor level above the T10, sensory level is above T8, autonomic level is above T12, reflex level is above T10, and spinal level is T8, vertebral level is T5. Extradural, extramedullary. Possible etiology is tuberculosis and part spine. Horizontal level left, right, vertical level is there. Motor level is above T10, sensory is above at T8, autonomic level is above T12, and reflex level above T10, so level is T8, vertical level is T5. Then for extrapyramidal, like Parkinson's disease, you have one second. So for extrapyramidal, you have Parkinson's disease, which is insidious onset, slowly progressive, Degenerative disease involving the motor nervous system in the form of rigidity and tremors with no evidence of sensory, cranial nerves, or bowel bladder. We would consider involvement of extrapyramidal system, most probably Parkinsonism, with no evidence of secondary causes, no signs or symptoms of Parkinson's, plus syndromes, and functional status, the stage 3 Hohen-Yahr staging syndrome. You have to use. For ataxia, it is insidious onset, slowly progressive, symmetrical ataxia, and cerebellar signs of trunk and limbs with no evidence of sensory, cranial nerve, or autonomic involvement. I would like to consider the possibility of degenerative cerebellar ataxia, possibly inherited. Family positive is positive though. Then central nervous system, discussion on this cardinal signs. So discussion on cardinal symptoms, you have to take neurological history. The neurological history should be focused, goal-oriented exercise that seeks to answer the following question. Which part of the nervous system is affected by a pathological process and is causing the symptoms? Where is the lesion? Is it a single lesion or is there multiple diffuse lesions? Alternatively, is there a diffuse problem affecting many neurological systems? What is the underlying pathological process? Example, vascular, inflammatory, degenerative. Is it a purely neurological problem or a neurological manifestation of a systemic disease? Note, ask the patient to tell their story in their own words. Explore each symptom in detail, evaluating the evolution and the way the symptoms affects the ability to function. Ask for an eyewitness account when the condition or consciousness is involved. If you cannot make a neurological diagnosis, take the history again before arranging investigations. So, pathology of neurological disease, you have acute, subacute, and chronic. Acute, you have vascular, which is stroke, demyelination, and metabolic. Subacute, you have infection, space occupying lesions, and metabolic. Chronic, you have degeneration. Then, higher mental function, you have altered status of consciousness, onset, any seizure blackouts, any fall or injury, any ear or nosebleed, fever, any ear pain or discharge, drug history, and any addictions. Other higher mental function, we have speech difficulty, difficulty to recognize people or object, memory deficits, and inappropriate crying or laughter. What is the underlying pathological problem? For example, vascular, inflammatory, degenerative. Uh, I just have to check something out. Acute, subacute, and chronic. Higher mental functions have altered status of consciousness. Onset, any seizure, blackouts, any fall or injury, Any ear or nose bleeding, fever, any beer pain or discharge, drug history, any addictions, mental functions, um, lack of interest, social disinhibition, delusions, hallucinations, mental state and cognition, change in the memory, change state of alertness and drowsiness, changes in the mood and affect, loss of spontaneity. You have language changes, you have loss of spatial orientation, diminished ability to carry out routine activities of daily living. Then cranial nerve dysfunction, you need to ask about cranial nerve 1, which is having smell disturbance, 2, 3 and 6 diplopia, blurred vision, blindness, difficulty in opening the eyelid, 6, 5 is difficulty in chewing and loss of sensation of face, 7 is deviation of angle of mouth, accumulation of food in one side of the mouth, dribbling of saliva, loss of taste, sensation and hyperacusis, 8 is tinnitus, hearing loss, dizziness, loss of balance, 9 and 10 is nasal intonation, nasal regurgitation of food, dysphagia, difficulty in speech, hoarseness of voice. Then 11 is difficulty in neck or shoulder movements. 12 is difficulty in mixing food in the mouth, difficulty in speech. So, for example, left lower motor nerve, seventh nerve palsy, history of reticuloauricular pain, followed by abrupt onset, deviation of angle of mouth to the right with slurring of speech and difficulty in left eye closure with history of hyperacusis. Motor dysfunction, you have weakness. Dissipation of weakness, is it symmetrical or asymmetrical? You have plegia, which is complete loss of power, 0 to 5 versus paresis, incomplete loss of power. Then incomplete loss of power. One limb is monoparesis, two limbs is hemiparesis, both lower limbs are paraparesis, all four limbs is quadriparesis or tetraparesis, and pentaplegia is spinal cord injury at level above C4 level result in complete loss of motor function below the injury level and paralysis of respiratory muscles also. Two contralateral to each other or three limbs, upper and lower limbs, example right limb and left to lower limb, and both arms and one leg. So pattern weakness, I have the pattern of pyramidal weakness is the weakness of upper limbs extensors and lower limbs flexors. For example, middle cerebral artery territory embolic infarct. History of sudden onset complete loss of power in the left upper limb, lower limb associated with left upper motor nerve, facial palsy. Weakness is maximum at onset and is non-progressive. Then you have causes of monoplegia affecting the lower limb and causes of monoplegia affecting the upper limb. Lower limb stroke affecting the anterior cerebral artery territory. You have cerebral venous sinus thrombosis affecting the superior sagittal sinus. You have trauma, head injury with confusion in the frontal lobe. Infections such as granuloma affecting the frontal lobe. Trauma to the lumbosacral plexus and diabetic lumbosacral plexopathy and functional or psychogenic. Then you have monoplegia affecting the upper limb, stroke affecting superior division of contralateral middle cerebral artery territory, affecting parietal lobe and impaired anterior cerebral artery, head injury with confusion in the parietal lobe, trauma to the brachial plexus, injury to the multiple cervical nerves, and functional or psychogenic. Then causes of hemiplegia, you have ischemic or hemorrhagic stroke affecting contralateral cerebral hemisphere, internal capsule, brainstem or ipsilateral upper cervical cord. Cerebral vascular sinus thrombosis with venous infarction of contralateral cerebral hemisphere. You have acute CNS infections such as meningitis, encephalitis, brain abscess, granulomatous infection. Head injury causing confusion, bleeding in the contralateral cerebral hemisphere, internal capsule, basal ganglia or brainstem. Tumor affecting the cerebral hemisphere, internal capsule, basal ganglia, brainstem or cervical cord. Leading into a brain tumor on the contralateral side. Demyelinating illness such as acute disseminated encephalomyelitis ADEM or multiple sclerosis MS. You have Todd's paresis and Mills hemiplegic variant of motor neuron disease MND. Causes of quadriplegia, upper motor neuron causes and lower motor neuron causes. Upper motor neuron causes cerebral palsy, bilateral brain subluxation, glioma, craniovertebral junction anomaly, high cervical cord compression, multiple sclerosis, and motor neuron disease. Low motor neuron causes acute anterior polymyelitis, GB syndrome, peripheral neuropathy, myelopathy, polymyositis, myasthenia gravis, periodic paralysis, snake bite, organophosphorus poisoning, etc. Mm-hmm. Causes of paraplegia, causes of flaccid paraplegia is lower motor neuron type, upper motor neuron lesion in shock stage examples. So that is sudden onset or history of long duration as in extradural transverse myelitis and spinal cord injury. Lesions involving anterior console in acute anterior polymyelitis, progressive multimuscular atrophy, a variety of motor neuron disease. So diseases affecting nerve root, you have taste as well as radiculitis, GB syndrome. Diseases affecting peripheral nerves, you have acute infective polyneuropathy, GB syndrome, high caudal syndrome, disease of peripheral nerves involving both of the lower limbs. You have lumbar plexus injury, psoas sepsis or hematoma. Then you have diseases affecting neuronal junction. You have myasthenia gravis, Lambert-Eaton syndrome, periodic paralysis due to hypo or hyperkalemia, and diseases affecting the muscles, myopathy. Onset and progression, you have acute, subacute or chronic. You have reversible, stable, non-reversible, fluctuating, stuttering or stepladder or progressive. Ascending weakness is first lower limbs, then upper limbs, then GB syndrome, then extramedullary compressive myelopathy. Descending weakness, you have first upper limbs, then lower limb, then Miller-Fisher variant of GB syndrome and intramedullary compressive myelopathy. You also have Ellsberg phenomenon, which is compressive lesions near the high cervical cord producing weakness of the ipsilateral shoulder and arm, followed by weakness of the ipsilateral leg, then the contralateral leg, then finally the contralateral arm. An anti-clockwise pattern that may begin in any of the four limbs. Extramedullary compressive myelopathy. Results near the high cervical cord produce weakness of the ipsilateral shoulder and arm, followed by weakness of the ipsilateral leg, then the contralateral leg, then finally the anti-clockwise outflow that may begin in any of the four limbs. Ellsberg phenomenon. Okay, ascending weakness is upper limb, then lower limb. First lower limbs, then upper limbs. It is GB syndrome, extramedullary compressive myelopathy. Descending first upper limbs, then lower limb is Miller-Fisher variant of GB syndrome and intramedullary compressive myelopathy. Now once again, GB syndrome I want to check out a little bit. GB syndrome is So Guillain-Barré syndrome, it is an immune system. It is a condition in which the immune system attacks the nerves. It may be triggered by acute bacterial or viral infection or vaccine, where a person's immune system attacks a peripheral nerve. It is very rare. Muscle weakness, abnormality walking, problem with coordination will be seen. So treatment, you can give blood transfusion, mechanical ventilation and intubation, and physical therapy can be done. Plasma exam and plasmapheresis. Infected polyneuropathy, acute infected polyneuropathy is high cardiac venous. This is affecting peripheral node species. More limbs, more plexus areas, abscess or hematoma. Lambert-Eaton syndrome, I'm saying this. Lambert-Eaton syndrome, so check. I do not remember this also. It's a rare autoimmune disease characterized by weakness of limbs, also known as myasthenic syndrome. So Lambert-Eaton syndrome often stems from lung cancer, whereas myasthenia gravis can be non-cancerous tumor or problem with thymus glands. Okay, I can relax with this. Then onset and progression, periodic paralysis due to hypo or hyperkalemia, disease affecting the muscles, you have myopathy. Onset and progression, you have acute, subacute or chronic. You have reversible, stable, non-reversible, fluctuating, stuttering or stepladder, or progressive. Ascending weakness, first you have lower limbs, upper limbs. Okay, yeah, this is in your told. Causes of spastic paraplegia, you have upper motor neuron lesions, you have gradual onset and you have acute onset, sudden onset. Spastic paraplegia, cerebellar causes which are gradual onset are parasagittal meningioma, hydrocephalus. If cerebral causes of sudden onset of spastic paraplegia, upper motor neuron type lesion is thrombosis of unpaired anterior cerebral artery or superior sagittal sinus. Thrombosis. Sudden onset is generally thrombosis or venous some problem. Then spinal cord, unpaired anterior cerebral artery or parasagittal meningioma, sagittal, parasagittal meningioma, hydrocephalus. Then spinal causes of spastic paraplegia, which is gradual onset, are compression or transverse in the spinal cord compression. Non-compressive or longitudinal lesion of systemic disease of spinal cord, you have motor neuron disease, example amyotrophic lateral sclerosis, multiple sclerosis, Friedreich's ataxia, subacute combined degeneration with from vitamin B12 deficiency, and lathyrism, syringomalacia, or spastic paraplegia, tropical spastic paraplegia, radiation myelopathy. All of these are non-compressive longitudinal lesion or systemic disease of the spinal cord. Compressive causes, you have injury to the spinal cord, fracture, dislocation or collapse of the vertebra, intervertebral disc prolapse, you have spinal epidural abscess or hematoma. Non-compressive causes, acute transverse myelitis, thrombosis of anterior spinal artery, hematomylia from arteriovenous malformation, angiomas or endarteritis. Sudden onset compressive causes of spinal upper motor spastic paraplegia. You have compressive causes, which is injury to the nerve cord, fracture dislocation or collapse of the vertebra, intervertebral disc prolapse, spinal epidural abscess or hematoma. Non-compressive causes, you have acute transverse myelitis. You have thrombosis of anterior spinal artery. Hematomylia from arteriovenous malformation, hemangiomas or endarteritis. Okay, then muscles or limbs involved. You have proximal upper limb, shoulder or arm. It is difficulty combing hair, reaching high places, swinging of scapula. Distal upper limb, you have forearm or hand. You have finger, wrist job, finger or wrist top. Poor hand grip, cannot open jar. Difficulty in buttoning and unbuttoning. Proximal lower limb is cannot raise from chair, squatting position, modeling weight. Distal lower limb, leg or foot is difficulty in gripping chappals. Cannot walk on heels or toes. Foot drop. Neck muscles, you have dropped head or broken neck. And trunk, you have inability to roll on the bed. Proximal upper limb is up. Okay. Then muscles and paralysis we have done. Variation throughout the day. Fatigability. In post-synaptic neuromuscular junction disorders like myasthenia gravis, the weakness worsens on exertion. So wasting or loss of muscle bulk. Wasting is a feature of lower motor neuron disease. Florid wasting is seen in motor neuron disease. It is usually associated with fasciculations in the late stage of upper motor neuron disease. Disease atrophy may also be seen. So wasting of muscles also results in undue prominence of underlying bones. It is a feature of lower motor neuron disease. Florid wasting is seen in motor neuron disease, usually associated with fasciculations in later stage of upper motor neuron disease. Disease atrophy may be seen. Stiffness of limb, increased tone of the limb results in stiffness and heaviness of limbs is a characteristic feature of upper motor neuron disease. Patients may complain that the limbs are heavy as a log in spasticity, when they may also say that limbs are floppy in lower motor neuron disease. So, variation throughout the day, fatigability, myasthenia gravis, the weakness worsens on exertion. Gait abnormality, it may aid the diagnosis. Limp or dragging foot might suggest lower motor neuron disease or foot drop. Scissoring or circumduction may suggest upper motor neuron diseases. Okay, all involuntary movements, you have type, symmetrical or asymmetrical, part of the body involved, present or traced, and functional disability. Four pages. Then sensory dysfunction, you have numbness, loss of feeling, altered feeling is paresthesia, distance This is here. Tingling or pin needles and spontaneous pain is also there. So pattern of sensory loss, you have heavy sensory loss is same side of the face and body. Cross sensory loss is one side of the face, opposite side of the body. So same heavy sensory loss, same side is internal capsule and thalamus. Crossed sensory is one side of the face, opposite side of the body is lateral medullary. Lateral part of medulla. Okay. Ascending sensory loss, lower limbs then upper limbs is extramedullary compressive myeloplasty. In descending sensory loss, upper limbs then lower limbs is intramedullary compressive myelopathy. Then dissociative sensory loss, only pain and temperature is lost, and posterior column sensation is present. It is intramedullary compressive myelopathy, lateral medullary syndrome, and anterior cord syndrome. Definite sensory loss, below which all sensation is lost, is suggestive of spinal cord disease. Graded sensory loss is glove and stocking. It is suggestive of peripheral neuropathy. So positive and negative symptoms have abnormal sensory symptoms can be divided into two categories: positive and negative. Positive symptoms are altered sensation that are described as pricking, band-like, lightning-like, shooting feelings, lancinations, aching, knife-like, burning, scarring, electrical, and such symptoms are often painful. Then positive phenomenon usually result from a trance of trains of impulse generated at sites of lower threshold or heightened excitability along with the peripheral or central sensory pathway. Because positive phenomenon represents excessive activity in sensory pathway, they may or may not be associated with sensory deficit on examination. Heightened excitability along peripheral or central sensory pathway. Negative symptoms represent loss of sensory function and are characterized by diminished or absent feelings that is often experienced as numbness and by abnormal findings on sensory examination. It is estimated that at least one half of the afferent axons innervating a particular site are lost or functionless before a sensory deficit can be demonstrated by clinical examination. Positive symptoms are increased, negative symptoms are absent. Then it is estimated at least half of the afferent axons innervating a particular site are lost or are functionless before a sensory deficit can be demonstrated by clinical examination. Just a second. I got a little bit distracted. I don't really look. Yeah, okay. At least one of the afferent axons innervating a particular site are lost or are functionless before a sensory deficit can be demonstrated by clinical examination. Clinical degrees of sensory dysfunction may be relieved by sensory nerve conduction studies, whereas sensory symptoms may be either positive or negative. Sensory signs on examination are always measured on negative phenomena. So pain, you do pinprick, it is cutaneous nociceptors, fiber size mediating is small. Temperature, you have heat, which is warm metal object. Cutaneous thermoceptors for hot. The fiber size mediating is small. Temperature, cold is cold metal object. Cutaneous temperature, the thermoreceptors for cold, which is small. Touch is cotton wisp, fine brush. Cutaneous microreceptors, also naked endings. Large and small fibers, you can see. Vibration tuning fork 128 Hz. Mechanoceptors, especially Pacinian corpuscles. This fiber mediator is large. Joint position, passive movements of specific joints in the joint capsule, tendon endings, muscle spindles, and they are large. Cutaneous mechanoceptors, also naked endings. This mechanoceptor is very pouch in corpuscles, muscle spindles, large capsule, tendons, and cerebellar examination, disc coordination and balance, difficulty in walking, unsteadiness, falls, staggering, and loss of balance in the dark. You have autonomic dysfunction, you have bladder dysfunction, urinary retention is not there, loss of awareness of bladder control, frequency, urgency, urge, and overflow maintenance. Then you have meningeal signs, headache, projection vomiting, photophobia, and neck pain. Meningeal signs, you have headache, projectile vomiting, photophobia, and neck pain. Others, you have dizziness, vertigo, blackout, and fatigue. Dizziness is many complaints, a vague feeling of unsteadiness to severe vertigo, frequently described acute vertigo. It is frequently used to describe lightheadedness felt in panic and anxiety during palpitations and in syncope or chronic ill health. Nature of these symptoms must be determined. Vertigo is an illusion of movement. It is more definite. It is a sensation of rotation or tipping. Patient feels the surrounding are spinning or moving, distinctly unpleasant, often accompanied by nausea and vomiting. Blackouts, light dizziness are descriptive terms implying either altered consciousness, visual disturbance, or falling. Epilepsy, syncope, hypoglycemia, anemia must be considered. However, no sinister cause can be found, and history of from a eyewitness is essential. Fatigue is another common symptom of neurological disorders. So we have various causes of neurogenic bladder, uninhibited autonomic bladder or detrusor sphincter dyssynergia, autonomic bladder or detrusor or areflexia, sensory atonic bladder, and motor atonic bladder. So this table is not that important. They don't really ask that much, but you can learn it. Uninhibited or detrusal hyperreflexia is suprapontine neurologic disorder mostly affecting frontal lobe, frontal tumor, parasagittal meningioma, ACA, and aneurysm in PH. They haven't kept a guide. I don't know what this is. Anterior cerebral artery aneurysm, NPH. I don't know. Non-pituitary something. I don't know. Bladder sensation will be preserved and size of bladder is normal. Ability to initiate voiding is present. Type of incontinence is an urge or social disinhibition. Residual urine is nil. Treatment is anticholinergic medication, bulboreconosis or renal reflex or perianal sensation and normal in the sphincter atomicin. Detrusor hyperreflexion. Then you have automatic bladder or detrusor sphincter dyssynergia. Site of lesion is the upper motor neuron disorder of the supracranial spinal cord. Suprasacral spinal cord caused by spinal cord trauma, compressive myelopathy, and myelitis. Bladder sensation will be interrupted. Size of the bladder will be small. Ability to initiate voiding is absent, and a type of incontinence is urge incontinence. Residual volume is small. Inner sphincter tone is normal. Perianal sensation is normal. Lower cavernous reflex or reflex is normal. Treatment is self-intermittent catheterization. Automatic detrusor synergistic dyssynergia. Autonomous bladder or detrusor e-reflection. Low motor lesion at sacral cord, caudal coronal syndrome, caudal spinal medullary lesion, spinal shock. Bladder sensation will be absent. Size of bladder will be large. Ability to initiate voiding is absent. And the type of incontinence is overflow incontinence. Residual urine will be large amount. Anal sphincter tone will also be lost. Perianal sensation is absent and lower cavernous or the reflex is absent. You have to do continuous catheterization. Then sensory atonic bladder and motor atonic bladder both are low motor lesion peripheral. It is sensory is seen in diabetes mellitus, amyloidosis, Tapes dorsalis. Our motor is seen in lumbosacral, meningomyelocele, thyroid cord syndrome, and lumbar canal stenosis. So bladder sensation is absent. It will be intact in motor. Sensation is absent in sensory. Size of the bladder is large in both of them. Ability to initiate is present in sensory. However, it is lost in motor. Type of incontinence is overflow incontinence, and residual urine is large. Both of them. Perianal sphincter tone is normal in sensory. However, it is lost in motor. The sensation and the reflex is lost in sensory. It is preserved in the motor. Treatment is again continuous catheterization in both of them. Finally, this board topic I will do and I'll sleep. I cannot. And I can study till for 3, but I don't want to. There's no use pushing myself, and besides, I think I will stop. Neck pain, infantile tot and deformities, you have infantile torticollis. Infection of wound, you have TB of cervical spine, phylogeny, infection of cervical spine. Tumors, you have benign and malignant tumors in relation to cervical spine and adults. Arthritis of spinal joints, you have rheumatoid arthritis and curvaceous spondylosis, RAAS. Then cervical spondylosis. Mechanical derangement, you have prolapsed cervical disc, cervical spondylolithiasis, whiplash injury, cervical spine fracture, neck muscle strain, and neck sprain. In referred pain, you have ear, throat, brachial plexus, angina, pain extends to the neck, aortic aneurysms, and meningismus. So backache, you have musculoskeletal, non-specific musculoskeletal like spondylosis, spondylolithiasis, scoliosis, Kuhlmann disease, disc degeneration, and or prolapse. Infections, you have discitis, vertebral osteomyelitis including Pott's disease, epidural abscess, scleroderma, joint infection. Others, you have intervertebral disc calcification, congenital abscess of pedicle, vertebral apophyseal fracture, aneurysm, bone cyst, scleroiliac joint stress reaction, idiopathic juvenile osteoporosis. Non-spinal infection, you have paraspinous muscle abscess, pyelonephritis, pneumonia, pelvic inflammatory disease, endocarditis, fibromyalgia. Inflammatory, you have alcoholizing spondylitis, psoriatic arthritis, inflammatory bowel disease, autoimmune arthritis, reactive arthritis. Neoplasia is osteoid, osteoma, leukemia, lymphoma, solid malignancy, primary or metastatic. Other than benign tumor, you have neurofibroma and vascular malformation. Others, you have appendicitis, sickle cell pain, pharyngomegalia, cholecystitis, and pancreatitis. You have recurrent chronic recurrent multifocal osteomyelitis, psychosomatic illness, nephrolithiasis, atrial junction obstruction. Then you have red flags for acute low back pain, cancer, unexpected weight loss, immunosuppression, prolonged sustain, etc. Others like this. UTI, pain worsened night or when sublime, fever, self-pain, trauma related to use, bowel blood incontinence, urinary retention, overflow incontinence, physical examination, cerebral anesthesia, loss of anal sphincter, major muscle weakness in lower extremities, fever, vertebral tenderness, limited range of motion, neurogenic findings persisting beyond 1 month. And that's it that I can do today. Oh my god, I'm tired. This challenge, honestly, if you want to think the challenge is failed, you can. I know for a fact it's been failed for some time, but today I did finish a big chunk of the topics which I wanted to do. I finished RS, I finished abdomen, and I finished, well, I started CNS. And I am happy, even though I might have just studied for like 5 hours today. Let's see, 1, 2, 3, 4. I slept for 3, 5, 6, 7. 7 hours. In that 7 hours, pakka some 2 hours, 3 hours I took break, so 4 hours I studied. And yeah, 7 hours is continuing with this also. Fine. So I'm going to stop streaming now, and yeah, thank you for watching this stream. See you guys in tomorrow's stream. Mostly I will finish CNS in 2 days, 2 streams. Tomorrow when I come back around 5 I'll start. I'll finish it off at 11 or 12. I would actually I think I'll finish around I did 26 to 37, so 10 pages I did now. I'll do another at least I'll do until 380, which I think is, yeah, cranial nerves I'll try to finish. At least cranial nerve examination I'll finish. There's a lot of things, but all of these things, not everything is important. CNS is such an extensive topic that there's no way everything will be involved. I mean, motor examination is simplest, I feel. You just have to do tone and a lot of these things. These tables are useless, genuinely useless. Then, yeah, these images will take a very short time. I can do motor and reflexes. Motor and reflexes are very easy. Sensory system examination might be difficult, and no, it's also only images. A lot of these are images, I can agree, but a lot of them are also very important topics. Cerebellar and gait is okay, we can do it in 1 day, and involuntary motions. So up until cranial nerve is the big problem one. Cranial nerves, if I finish, I'm good. Cranial nerves and muscles, if I can finish, I'm good. Motor system examination is genuinely not needed. Reflexes, coordination, gait, you can do that on your own. Peripheral sensations I want to do, but yeah, it will take a long time. Tomorrow, if possible, I'll finish this. Mostly cranial nerves if I finish, and that's all is possible. Genuinely, I feel that's all that is possible before my exam. I don't think I can ever finish motor system examination. I will read on my own, but I doubt I can finish it properly. There are so many things. Analyzing personal weakening, digital weakening, so many things are there. So yeah, I'll catch you guys in the next episode. Stay tuned, and yeah, I'm just going to stop the stream.